everyone to the second session of a webinar with MERG Kolkata Medical Education and Research Group. It is a new initiative with Dr. Sauran Panja and a team of other doctors. So in the second session, I welcome Dr. Nirmalo Roy. He will be speaking on the various mechanisms of actions of oral anti-diabetic drugs. Over to you, Dr. Nirmalo. He is a professor, Department of Medicine, KPC Medical College and Hospital. We welcome you all, and we welcome Dr. Nirmalo on board. Over to you, Dr. Nirmalo.
Thank you. Thank you. In fact, this is one of my first webinars where I'll be navigating across the slides on my own. I wanted to do it, but then on all the last webinars, I have actually taken the help of a coordinator who was navigating across the slides. I thought I'll change it to something more practical, something more useful, where we talk of how to use the oral anti-diabetic drugs. Well, whether you love diabetes, whether you hate diabetes, you just can't ignore diabetes. It is essential for us in whatever field that we are in, that we have a fair amount of knowledge of diabetes. What has become all the more difficult these days is the fact that we have so many drugs to choose from when it comes to treating a diabetic patient. I remember when I was in school and my father was diagnosed with diabetes, and we were all very nervous thinking that my father will be put on insulin. But at that time, my father was started on a magic drug called Glinase, and this is something I'm talking about some maybe 18 years back, 20, maybe, yeah, it's more than that, 20 years back, 25 years back. And at that time, my family doctor didn't have much to choose from, because that was perhaps the only drug available at that time, and I was still in school, so that much I can remember so far as treating diabetic patients in that era is concerned. But now things have changed fast, and we are living in a new kind of normal, and it has become all the more difficult that we have to make a prudent choice so far as oral anti-diabetic drugs are concerned. If you look at the whole lot of patients who are standing in front of us, they are all different. Mr. Agarwal is an obese gentleman, loves to sit on his couch, but then this is something we just can't allow him to do. But then he needs his kind of treatment. While Mr. Roy looks very active and he runs about and he maintains a good HbA1c, perhaps too good. Then these two young ladies who are not slim, but then they have their own goals. They want to look good. And we have this lady above running from railway stations to houses where she works as a maid servant. She has her own concern. She cannot spend a big lot of money on oral anti-diabetic drug. And this lady finally, who's returning after a marketing sojourn, is somebody who's looking for a drug which will make her life easy, at the same time taking care of the fact that it's not something which is going to hurt her. Having said this, let me go into the topic proper. So with this, we as doctors, we always do things better when we have a patient sitting in front of this. She is a patient of mine. She's a 76-year-old widow, retired professor with a son staying at Bangalore. She has been a diabetic for 8 years on metformin 1 gram twice daily, and her fasting stands at 160 and PP 245, HbA1c of 8.2, creat of 0.9, and weight of 80 kilo. Her BMI is 32, and she has recovered from a Colles fracture recently. Any suggestion what can be her second drug? Any suggestion like what can be her second drug? How do I see if there's a suggestion? Never mind, I'll go across to the so these are the days of acute care, and I understand most of the doctors who are participating in this webinar are like acute care. But in chronic care, things are very different. I enjoy my chronic care. I deal with non-communicable diseases and diabetes in particular, and we have a laid-back attitude. We don't have that kind of um, hurried attitude as doctors in acute care would be perhaps having. But then it's essential for us to understand the patient psychology before we actually start treating patients. Well, we all always look for patients who are ideal. They do the best. You tell them anything, you tell them about 4 shots of insulin, they will readily agree to 4 shots of insulin. But then you don't see much of these patients. Too much to bear. Now, these are the patients who tend to do well if you provide provide them with extra support. And most of the patients probably belong to this class. If you give them time, they tend to listen. If you tend to answer your questions, they tend to follow up with you. This is something of very common human attitude. Now, I'm very scared of this third attitude, the IKEA or I know it all group. They do well if the doctor, in fact, they're very difficult to deal with. These are the patients who will tell you about the side effects of metformin, and when you talk of SGLT2 inhibitors, they'll tell you about the various side effects of SGLT2 inhibitors, and they'll lecture you on Baba Ramdev's powder. Chalta hai, well, they are very pleasant type of patients. They come, they smile at you, and their sugars are never controlled. I remember being a doctor to a Marwari lady who had always been a very gentle person, and I was quite happy treating her. But the worst part of the story was she never got controlled, and every time she used to come and I would tell her to be more careful, she would promise agle baar sab theek ho jayega. And I saw her moving from one drug to 2 drugs to 3 drugs to insulin and developing CKD, getting hitched to dialysis, and finally dying on a dialysis machine. And believe me, she kept telling me, "Agle baar sab theek ho jayega, Doctor Saab," which is something which never happened. So the things that I'm going to discuss about the treatment modalities, how I'm going to navigate across treatment, the targets which are to be achieved over a reasonable timeline, and recommendation of follow-up, early identification and treatment of complications. So as I've told you, it's essential for us in whatever field that we may be. Diabetes is something we just can't afford to forget. Gone are the days when type 1 diabetes happened to be a simple disease of insulinopenia. Well, type 1 continues largely as a disease of insulinopenia, but then the type 2 diabetic patients enjoy a more complicated pathogenesis than type 1 diabetes patients. And it is essential that we as doctors develop drugs which are applicable to each of the key connecting points of the pathogenesis. Type 2 diabetes does not remain a simple disease of insulin resistance at the level of muscle, adipose tissue, and liver, but it is also a fault or defect in the incretin pathway. We will talk of incretin pathway a little later. A system of a problem of relative insulinopenia and hard to please brain satiety centers. Even kidneys have evolved as a key player in the pathogenesis of type 2 diabetes mellitus. And needless to say, we have so many drugs actually working at so many levels to make sure that we achieve a good glycemic control. But unfortunately, only one third of the people actually manage to achieve good glycemic control despite us having so many choices. If you are looking for drugs which will increase the insulin secretions, you have secretagogues like sulfonylureas as well as meglitinides. Even DPP4 inhibitors are to some extent improve upon the secretion. You have GLP-1 analogs for muscle and fat insulin resistance mitigation. You have drugs like thiazolidinediones and metformin. If you want to make sure that the gut is not absorbing excess of the nutrients, then you have drugs like alpha glucosidase inhibitors. We understand these are the days of nutrient excess, and therefore we have to devise a method to throw out nutrients, and the gut has it by alpha glucosidase, while through kidney we threw out with SGLT2 inhibitors. And if you have the liver, which is as a concern of insulin resistance, you have drugs like biguanide, the metformin, as well as thiazolidinediones. If you look across the studies, it is essential for us to understand that when you are trying to achieve a good glycemic control, you should achieve it right from the beginning of the natural history of diabetes, not suddenly one fine day when you decide that you want to achieve good glycemic control and you end up tightening the patient's control. Rather, it should start from the day of inception of diabetes. When it comes to deciding on oral anti-diabetic drugs, it is essential that we do what is known as patient-centric medicine rather than disease-centric medicines. In fact, the disease-centric model of medicine is actually which has caused problem. It is essential for us to keep the patient at the center. How do we make a choice? We make a choice by attitude of the patient towards treatment. Somebody who's motivated for a good treatment, somebody who wants to make sure that he will achieve the targets. It is essential for you to go overboard and try out various kinds of therapy with that particular patient, making sure that the safety concern of the patients are foremost in your mind. Then there are patients like Mrs. Sengupta, as I've talked about, who stays alone largely, and it is essential that we cannot go proceed treating Mrs. Sengupta in a hurry, and as a result that she might end up with a hypoglycemia and a fall. Therefore, it is essential that we understand what kind of problem that the patient is. No other disease gives you the chance to practice social medicine as does diabetes. Then the duration of diabetes. Somebody who had a very poor control for last 20 years and you suddenly think that you're going to achieve a HbA1c 6.5% in 2 months time, well, he is not the case for you. It is essential that you go slow as you build up across the diabetes control. However, you need to be aggressive if the patient is young, if the patient is in the earlier part of the natural history of the disease. Life expectancy. I have seen patients being referred to me from oncology centers, oncology units, telling me to achieve tight glycemic control. What is very important for you to understand when you are trying to achieve a tight glycemic control in these kind of patients, whether what kind of treatment expectation does the patient or the oncologist or the treating physician wants. It may be that there is only a palliative intent in the oncology setup. Then what is the point in achieving tight glycemic control? You only need to mitigate the symptoms of hyperglycemia, the osmotic symptoms of hyperglycemia, or perhaps the patients don't succumb to infection earlier than what the patient's natural history would have allowed. However, the patient who's about to be on a curative treatment, so from the oncology point of view, it is essential for you to be quite aggressive, making sure that you achieve a good glycemic control. Important comorbidities. Somebody who cannot walk to the toilet easily, do you treat that patient with SGLT2 inhibitor? Answer is no. The poor man will end up waiting his bed, waiting his couch. I have seen patients who ride wheelchairs for osteoarthritis being treated with SGLT2 inhibitors, and the patient ending up with bed sores because he sits on his pool of urine. And it is essential for you to make sure that you give adequate importance to the comorbidities. Perhaps a person who has got an acute coronary syndrome recovering, and you have become very aggressive so far as its diabetes treatment is concerned, then also it can be quite cumbersome. It is also essential for us to understand the patient's resource and support system. As I've pointed out, when you prescribe an SGLT2 inhibitors like canagliflozin to a beggar woman or the med servant whom I showed, then you're surely not going to treat her at all. It is essential for us to understand what kind of drugs the patient will be able to afford. Not only that, if you deprive a patient who can procure expensive drugs, then also you are not being fair to the patient. You need to understand what kind of treatment the patient will do well with. So this brings us to something which is little different to, or perhaps an antithesis to what is known as preference-based medicine. It is essential for us to understand the setup and make sure the patient we understand the values and the preferences of the patient and set goals according to it. We need to debias our strategies and we need to respond to the emotions of the patient. It is essential again in chronic care that you don't work as a despot, but as somebody who seeks consensus. And all through your consultation, you should be assuring and should promise that even if you don't agree with the patient, the non-abandonment is the rule. Like, for example, it happens very commonly in diabetes practice. You talk of insulin, patient says no, and patient pleads for another oral anti-diabetic drugs, and you as a patient's physician understand that she needs or insulin, but maybe at times we need to listen to the patient, find out whether she'll respond to a next oral anti-diabetic drugs, and bargain that if it doesn't happen, then next time we will probably put the patient on insulin. It is essential for us to understand what kind of targets that we seek to achieve. HbA1c target as recommended by American Diabetes Association stands as HbA1c of less than 7% for most people, and a pre-meal glucose level between 80 to 130 and a post-meal value of less than 180. It's fair to achieve a tighter control when you're dealing with a younger, healthier person in early part of the natural history. However, it's not at all reasonable on part of the physician to achieve a tight glycemic control for a patient who's prone to hypoglycemic events, like, for example, Mrs. Sengupta. I'll skip this slide because when it comes to dealing with the diabetes, it is essential that we understand that medical nutrition therapy is very, very important. Just writing 1600 kilocalorie diet is something which is not good for as doctors. Rather, you discuss diet in terms of serving sizes, in simple terms. With this, I enter into the various arena of various oral anti-diabetic drugs. What are the various drugs that we have? We have oral agents like secretagogues, the sensitizers, alpha glucosidase inhibitors. We have incretin mimetics like liraglutide, exenatide, as well as SGLT2 inhibitors, as well as insulin. And with this, we take each of the drug in sequence. When it comes to starting oral anti-diabetic drugs, as doctors, we need to stress on the patient that that oral anti-diabetic drug and its subsequent addition is but the continuum of the care. Many patients will tell you how sincere he has been with his diet and exercise regime, and therefore is quite reluctant to start oral anti-diabetic drugs, or perhaps increase the doses of oral anti-diabetic drugs. In chronic care, it is also essential for us to provide clear written instructions regarding the drug dosage, when to take, and its relationship with food. Often, due to financial burden, patients are known to skip this expensive drug, and it is essential that we as doctors must evaluate whether the patients are actually taking the drugs. We also see the reverse. In fact, I remember seeing a patient who was religiously taking his Diavit capsule, which was quite expensive, but forgot to take the metformin, which was inexpensive, and he thought that metformin is probably not the real drug. It's the capsule anti-diabetic drug, vitamin capsule that he was given is the anti-diabetic drug, and therefore it is essential for us to understand whether the patient is probably taking those medicines or not. Unlike in acute care where patient is too sick to ask questions, but in a chronic care, the patients should be free to ask questions to the doctor regarding the side effects, because if you don't discuss the side effects, then there is a very high likelihood either the patient will run away from you, or perhaps the patient will stop taking the medicine if he feels very uncomfortable. Remember, one of the biggest problem in chronic care is that the patients are required to take these drugs for months, years together, and therefore it is essential that they be shown the right kind of way to deal with the day-to-day problem. Finally, nothing is complete in diabetes unless you talk of hypoglycemia. You should empower patients, teach them about symptoms of hypoglycemia, and make sure that the patients understand how to proceed with self-management of hypoglycemia. So with this, I enter the drugs. Okay, and skip the slides. So if you look at the various drugs that we have, most of the drugs are capable of bringing down the HbA1c on its own by 1 to 2%. And it is essential that we understand if the HbA1c is very, very high, then the only drug perhaps which can address this concern is that often is the insulin. So coming to oral secretagogues, we have got two agents in this group, insulin sulfonylureas, consisting of glibenclamide, glipizide, gliclazide, and glimepiride. Currently, we are more into using gliclazide and glimepiride. These are the drugs which have stood the test of time. Every time a new oral antidiabetic drug comes in, we start writing obituary of gliclazide and glimepiride. But what I can assure you, these are excellent drugs provided you use with a reasonable caution. These are the drugs which increase the secretion of insulin from pancreas and on their own can reduce the HbA1c by 1.5 to 2%. The concerns of insulin secretagogues, both sulfonylureas as well as meglitinides, remain as the weight gain and hypoglycemia. What is essential that whenever you prescribe this drug, you talk to the patients regarding how to avoid defensive snacking in case if the patient becomes very sincere with his diet and exercise regimen. It is prudent that he reduce the dose of oral antidiabetic drug. Weight gain that we get to see with insulin secretagogues is largely attributable to the fact that patients are scared of hypoglycemia and resorting to defensive snacking. We don't use the other oral anti-diabetic drugs. We use mostly glimepiride and gliclazide. Um, uh, Coming to glimepiride, it is a drug which is used once a day. It is seldom advisable to go above 4 milligram. These drugs do have a plateau, and for most of the drugs, for glimepiride, it's around 4 milligram, while for gliclazide, it's about 320 milligram or 120 milligram for extended release preparation. We used glipizide sometimes, particularly in patients with renal compromise, because these are the drugs with a shorter duration of action. It is essential when you start this drug, you consider certain important caveats. That is, you start low and go slow. So you should titrate it once in 2 weeks or once a week in case if it is responding very slowly. It is again prudent to dose these drugs just prior to the heaviest meal of the day, and patients as well as family members be told about how to deal with hypoglycemia. It is essential again that these drugs can be used as monotherapy, particularly for a patient who has got a contraindication for metformin and cannot use one of those expensive oral anti-diabetic drugs, or as a second line therapy if the patient again cannot afford one of the newer oral anti-diabetic drugs. However, these drugs are to be used with lot of precautions for those patients who are prone to hypoglycemia, like for example elderly people with renal impairment. These drugs are the drug of choice, particularly in some varieties of MODY as well as in neonatal diabetes, which I will skip for now. Now coming to the gold of diabetology. Whatever comes, it has to be compared, it has to be combined with the metformin, which continues to be the gold. Despite the fact that all the expensive drugs have come in, but none of the newer agents could displace metformin from its throne. It is a drug which improves the insulin resistance at the level of the liver. It lowers the glucose production by the liver, and by its own, it can reduce HbA1c up to 2%. However, this drug cannot be used for all practical purpose for a man with a creatinine of more than 1.5 and for a woman of creatinine of more than 1.4. It continues to be the what written in the label, but currently we have become more liberal. We understand that between 45 and 30 eGFR, you do not start metformin. However, if a patient is getting a benefit from metformin and the creatinine level remains stable between 30 and 45, you can continue with half dose of metformin safely, provided that you remember if this patient needs to undergo a contrast study or patient becomes unstable for any reason, metformin has to be transiently stopped. Patients with deranged liver functions, particularly belonging to class A, class B, or class C child group, is not a candidate for metformin. Nowadays, in stable heart failure, we do use metformin and metformin. Thiazolidinediones, well, these drugs, again, they became victim of the modern drugs and their obituary. The rosiglitazone has been removed from the list currently. It improves insulin resistance throughout the body, and however, it has got a problem of edema and worsening of congestive heart failure as well as weight gain. It is essential for you to understand if you're treating with a patient with pioglitazone, it is essential to rule out macular edema as well, because I've seen patients going blind because the doctor didn't take care of the fact that the patient was having macular edema, and which got worsened with thiazolidinedione. If you're treating patients with metformin, the trick is that you start with a low dose of 500 milligram and then go up to 1 gram twice daily. Well, sustained release and immediate release, they don't have much of difference. But then if a patient says that he's having gastric irritation, or so, you may try out sustained release tablets, but then they're all the same. It is essential for us to understand that when it comes to metformin, you do an up titration every 1 to 2 weeks if the patient is not comfortable with sudden increase of dose. And when it comes to thiazolidinedione, we use more of pioglitazone. Rosiglitazone is no longer available in the Indian market. When you're using pioglitazone, don't expect the diabetes controls very soon, because it's a drug which works at the genetic level, and therefore it is essential that you need to wait for a month before you actually see a tangible change in the glycemic status. However, it is essential for us to remember, if you pull out pioglitazone from the prescription suddenly, you don't see a deranged glucose suddenly, but maybe over time, as you may see a very poor glycemic control. It is essential whenever you start thiazolidinedione, you rule out conditions like heart failure, you rule out conditions like macular edema, and to at the same time realize that weight gain is a problem with pioglitazone. It is because of the redistribution of visceral fat and increase in subcutaneous fat, which is a good mechanism, but at the same time, this drug is notorious for causing saltwater retention. Thiazolidinediones are also notable for causing fractures, particularly in non-conventional sites so far as osteoporosis is concerned. Rosiglitazone ran into a lot of fiasco with poor cardiovascular problem, and therefore it is no longer available. Alpha glucosidase inhibitors, these drugs never became popular in the Western world because of the problem that they are to some extent associated with belching and farting, and which are not something with Westerners are comfortable with. And therefore, we use them more in our kind of practice. But when you go to practice which is guidelines which are largely dictated by Caucasian authorities, you don't see much of the use of these drugs. But nevertheless, these drugs are essential in our kind of practice where we eat a heavy carbohydrate based diet. If you're using these drugs, it is essential again that you tell the patient when you're using a drug like voglibose, 0.2 to 0.3 milligram up to thrice daily can be used before the meal or with the first bite of the meal. Sometimes we also give it once or twice a day instead of giving thrice a day. And these drugs are not very strong and can bring HbA1c down by only 0.8%. Next, we come to incretin hormones and DPP4 inhibitors. Now, this is an important area as well. It has been understood that whenever you start eating, a set of gut hormones are produced known as GIP and GLP-1. And these hormones convey the message to the pancreas that food is on the way, and the pancreas, as a result, start throwing out insulin. Now, these are the hormones which are deficient in the type 2 DM patients. And what happens when you have a scanty amount of these hormones, and that too, whatever scanty amount of hormones that you have, they get degraded by a set of enzymes called DPP4. You are left with very little of these essential hormones, and this is what is known as a place where DPP4 inhibitors actually come in play. We have over time we have understood that DPP4 inhibitors have got many other important factors apart from promoting carbohydrate induced insulin secretion, but it also improves insulin biosynthesis, preservation of beta cells, and improves beta cell longevity and improves upon and prevents insulin wastage by its glucose sensing insulin secretion. So, what is incretin effect? Incretin effect is whenever you're given a dose of glucose, the insulin secretion is more when you're given the oral dose of glucose than when you're given an IV dose of glucose. And this incremental value, because of oral dose of glucose leading to insulin secretion, is because of the incretin effect. So what these are the drug DPP4 inhibitors are very safe drugs. They can be used across all kinds of comorbidity. However, we don't use saxagliptin when the patient is having a heart failure, and gliptin like linagliptin does not require a dose change across any condition. However, they are not very strong drugs and very and not the kind of strong drugs, but they're useful drugs nevertheless. So sitagliptin is a commonly used agent. It can be used as 100 milligram once daily, or maybe in 50 milligrams twice daily in combination with metformin. We have other gliptins as well. I'll skip some of these slides. So another important issue that comes in is where do I get the SGLT2 inhibitor? 1 second. So we go to this another important oral anti-diabetic drugs. Over time, we have understood that normal renal glucose physiology, some 180 grams of glucose is filtered each day, and virtually all glucose is reabsorbed in the proximal tubules and re-enters circulation. SGLT2 inhibitors reabsorb about 90% of the glucose, and SGLT1 reabsorbs about 10% of the glucose. SGLT1 is largely situated in the gut. Now, what happens if you can block this SGLT2? Then largely these glucose are filtered out through the kidney, and this is a very important mechanism where you make the person shed his excess weight, as well as make sure that the patient weight, as well as and so far as mitigating the other problems of diabetes is concerned. We have drugs like dapagliflozin, empagliflozin, as well as canagliflozin, and perhaps Indian version rimogliflozin. It is essential when you choose these drugs that you are not using this drug in a patient who's having an EGFR of less than 45. If you're using it in a patient EGFR less than 45, the GFR may go down further. Though there has been an activity to reduce the cutoff for EGFR when you're using this drug to 30, but currently in India it still continues to be 45. For an elderly person, what are your concerns when you're treating an oral and a patient with anti-diabetic drug? Your concern is that the patient should not develop hypoglycemia, patient should not develop side effects. So, do you think SGLT2 inhibitors will be a good choice? Oftentimes, SGLT2 inhibitors will perhaps not be a very good choice for an elderly patient, particularly because of the fact many of these patients are not that mobile, particularly those who are wheelchair bound or bed bound. If you use these drugs, the patients may not be able to run to the toilet every time the patient feels urge, and as a result, there can be an excess of urinary tract infection. Moreover, these drugs are also not good choice if the patient has a prominent PAD or prominent um, prominent peripheral neuropathy, because there has been some episodes of a worsening of the diabetic foot with these drugs. It is essential that you don't use these drugs for those patients who are have had a history of Fournier's gangrene in the past, because these drugs are also contraindicated in such patients. However, they are excellent choice for patients who have a cardiac condition like heart failure, or patients who had a known coronary artery disease. These are also excellent drugs for patients who are trying to shed off excess of weight. When it comes to renal impairment, definitely you cannot use drugs like metformin, particularly if the eGFR is less than 30. Between 45 and 30, you use metformin with a lot of caution. SGLT2 inhibitors, as I've just discussed, currently in India, the threshold continues to be 45. Hepatic impairment, well, the only drug which can be used safely in hepatic impairment is perhaps linagliptin. However, remember, so far as other oral anti-diabetic drugs are concerned, till the patient is in child book class B, you can use them. You can even use glimepiride or gliclazide with caution in patients with known hepatic impairment but belonging to child book class A or perhaps class B early. We would always want to use insulin in these patients who are beyond child book B and beyond. Congestive heart failure, as I've just talked about, SGLT2 inhibitors is the way to go. Pregnancy, for all practical purpose, nothing is recommended in pregnancy except for insulin, and that too insulin, certain insulin, human insulins and certain insulin analogs only, and not all the insulin analogs, but certain insulin analogs only, as well as metformin. Other drugs are not quite recommended in pregnancy. What is also important for us, this is an old, I'll skip. It is essential whenever you're seeing a diabetic patient, it is essential as doctor for us to understand what are the other comorbidities of the person. If the comorbidities of the person figure out as a concern of as the cardiovascular disease is concerned, then you must tilt towards using drugs in addition to metformin as SGLT2 inhibitors. If the patients are can afford, and you can even offer them drugs like GLP-1 analog, which is an injectable agent. I'm skipping this because I'm only dealing with oral anti-diabetic drugs today. You may use DPP-4 inhibitors in these patients. Patients with obesity, you must remember that weight loss is something which we are trying to achieve, and therefore metformin combined with a SGLT2 inhibitor will be a good choice, or for that matter, metformin with GLP-1 analogs. And if patient cannot afford anything, then metformin with a DPP-4 inhibitor will be a good choice, largely free of side effects. Patients with excess of cardiovascular risk, then there also you can offer the patients SGLT2 inhibitors. Remember, in a hot humid climate like as we do, it is prudent that you understand what kind of patient you're dealing with. Recently, I had the opportunity of seeing a courier worker who has to run across the city delivering couriers, and this man had a stent implanted, maybe had a stent implanted a few months back, and some cardiologist has prescribed him an SGLT2 inhibitor along with metformin. Now imagine the plight of this poor man. He keeps looking for a toilet all across the city because he was on SGLT2 inhibitor. And one day, when he was having a very hectic schedule, this gentleman had to actually go running across the city and missed drinking adequate amount of water and ended up in the hospital in a very poorly dehydrated state. Therefore, as I've just emphasized, that it is essential as doctors that we give a lot of importance to the kind of patient that we are treating. Self-monitoring of blood glucose is a very important tool, and it is something that we must teach our patients. When we treat an elderly patient, we need to see the status of the man. If the man is non-frail, if the person is performing all the activities properly, then there's no reason why you should not deprive why you should deprive the patient of the benefits of the drugs like SGLT2 inhibitor. However, if you're treating a bedridden post-stroke patient, there's no point in prescribing an SGLT2 inhibitor in such patients and making his life worse by predisposing him to UTI. With this, I come to the end of today's session. I made a little change. I was supposed to talk on mechanism of oral anti-diabetic drugs, but I wanted to see whether the presentation is something which I can make properly. So I changed it off to making the right choice of oral anti-diabetic drugs. Though across the presentation, I did talk about of the mechanism of the drugs of each of the oral anti-diabetic drugs. Thank you. If there are questions, I'll be happy to take. Will the questions be audible?
I have requested everyone to post their questions. We are yet to have any questions.
Right.
They will not be audible. We'll be able to see it in the chat
I'll be able
box.
to see the questions. Okay.
And if anybody wants to speak, you can just press the request to speak button and we can take you online.
Okay.
So if anybody wants to speak, so we have Dr. Paja in the room. So sir, you want to add on?
Thank you, Dr. Neil.
Thank you, Shorinda, for being in attendance. It's always good when you,
It's excellent
to
presentation.
have you as an audience.
So, no, I was audience throughout the whole period. What happened because of some bad patients actually, So right now, some of
I
our
can understand you're going through a very difficult time.
doctor colleagues got admitted with some other problem. So I am engaged with all those commitment. So thank you for all the audience to be here, and I think it was an excellent, I would say, in a very short time that Marlo has basically explained the whole thing.
And I understand that despite the fact that most of the doctors in this audience happen to be from acute care setting, they took time out to listen to something as mundane, as ordinary as oral anti-diabetic drugs.
Not to acute care physician, they are all going to physician. Some are basically postgraduate training. And attendance was not that great. I am telling on an average there is an attendance of 25 to 30 attendance. But suddenly, actually, I was busy, so I could not make it a proper communication with all the interested candidates. And yes, time, whatever you have explained, it was an excellent year. And I have nothing to say. I think if there is
we
any
have a few
lecture,
questions,
I will request.
We have a few questions coming up. Yeah, we have a few questions coming up, Dr. Paja and Dr. Nirmal.
Chat box.
Yeah, it is on the chat box. I'll just read out the first question. The first question is...
I can see the question.
Yeah, OHA for a patient with NAFLD.
I think I have got the questions. Shanchari Ghosh, sir, please explain the advantages of DPP4 inhibitors. When it comes to DPP, is it the same Shanchari as at KPC or somebody else? Okay. It is essential for us to understand that DPP4 inhibitors are very simple drugs. The drugs don't have much of side effects. They're safe to prescribe. And when you're seeing the 50th patient in your OPD, it is very easy for you to actually prescribe DPP4 inhibitors. However, you need to remember that DPP4 inhibitors are not very strong oral anti-diabetic drug. Maybe for Mrs. Sengupta, the case whose problem we discussed, it was a good choice because she was scared of hypoglycemia, she was scared of of fractures. So maybe for Mrs. Sengupta, the case whose problem we discussed. Next question is, which situation should we choose GLP-1 analog? Dr. Amritendu Mondol, Dr. Mondal, it's essential that you select a GLP-1 analog first for those patients who can afford GLP-1 analogs. They are very expensive drugs. When you're using GLP-1 analogs, you must prime your patient for the fact that this drug may reduce your appetite, may increase nausea. These are two very important things that you must tell the patient. If the patient's problem happens to be a condition like obesity, then it's a very good way to motivate. However, these drugs are also strongly recommended for those patients who have had a cardiovascular event or who are predisposed to cardiovascular event more than any other ordinary patient after you have finished off using metformin. How do I go to the Nobendu Jana's question?
We have another question from Dr. Navendu Jana. Oral hypoglycemic for a patient with NAFLD. That is the question.
This is a good question because Dr. Jana, if you do ultrasonography for all diabetic patients, the answer comes back as maybe nothing significant except for non-alcoholic fatty liver disease. Now, these are important questions that you have got to ask yourself when you see this USG. Is the patient obese? If the patient is obese, then it is essential that you select a drug which will reduce his obesity significantly. Metformin with GLP-1 analog or metformin with SGLT2 inhibitors will be very effective in dealing with these patients. However, if the patient is ready to take a little bit of risk, as thiazolidine diones come with the recommendation for use in NAFLD. However, you have to be very, very sure that you are dealing with NAFLD only, not a person who takes alcohol surreptitiously, or perhaps a patient who has got a hepatitis B or C and his liver enzymes are not raised. In that case, you can carefully use drugs like pioglitazone. For all practical purpose, when you're dealing with non-alcoholic fatty liver disease, the questions that you're going to answer before starting the medicine: number one, the patient's liver function test, the patient's prothrombin time, to exclude that there is no acute derangement in this patient. Next important thing is that you make sure that if the weight is a concern, you focus on drugs like SGLT2 inhibitors as well as GLP-1 analogs, particularly after having finished off with metformin. How do I go to other questions? I don't think there are any more questions, right?
There are no more questions as of now.
Okay, thank you. I enjoyed also speaking in this forum. Thank you very much.
Let us have many more sessions. Please kindly share your feedbacks, discussing with everyone who are present out here as delegates. Please share your feedbacks and you will get a certificate as soon as you share your feedbacks. E-certificate from Dr. Paja and team. So thank you, Dr. Paja. Thank you, Dr. Roy. So we are signing off. Thank you everyone for joining us.